Hello, friends. So today I'll be talking on this interesting debate which was given to me in Hyderabad for the conference that happened on 18th November 2023. So the topic given was quite intriguing to me. The topic is it time or it is time rather to bid farewell to mechanical ventilation in ARDS. So I'm sure every listener would possibly uh, look in awestruck as to how come one can talk on this topic. So, because in ARDS, we know the bread and butter of ARDS is good ventilation and protective lungs. So, here I am trying to debate that it's time to bid farewell to mechanical ventilation. So, I felt it is the organizers who gave me this talk is to prove that crow is white. So, there's a lot of bias as you can see. So, and it's very hard to debate such topic. Nevertheless, so we'll see how best we can argue that ventilation is something that may eventually become obsolete. So we'll more look into the conceptual understanding and the future that holds for this topic. So the way we would go look at this topic is try to understand what are the pitfalls in the management of mechanical ventilation. So we need to now argue and say there are a lot of pitfalls in mechanical ventilation in ARDS. So some of the pitfalls, recognized pitfalls is there could be significant delay in identification of this entity of ARDS in first place. And we know for sure that low tidal volume ventilation not always is easy to attain. The goals that we have in mind is not easy to attain and achieve. And we do not know for sure what is the best tidal volume for a given patient with a given condition and with whatever severity of ARDS one is having. And this is, I'm sure every listener here would agree that PEEP optimization is a huge sort of a debatable topic. And for every patient, the optimal PEEP is distinctly very different. And there are huge challenges with regards to clinicians' ability to determine what is the optimal PEEP for a given patient, for the given patient with the type of ARDS one may be having. And again, we have a huge debate on FiO2 optimization. So, what is the right amount of oxygen one should attain? And FiO2 that one should be maintained on. So, these are all the nebulous areas that a clinician is faced with when one is dealing with ARDS. And there is significant patient ventilator asynchrony because of various reasons and the amount of sedation the patient may be needing, analgesics one may be needing, neuromuscular blockers, double triggering. So there are so many caveats and factors which has an enormous influence on the synchrony pattern. And I'll talk a bit on this as well. And there are changing needs of these ventilation. So the ventilator that you may have set for a patient at one point of time in ARDS, not necessarily is the same at a different point because it is a very fluidic. The whole process of ARDS is very dynamic and fluidic and it keeps changing. And so is the ventilator needs that keep changing. And it's humanly not possible for a clinician to keep on tweaking various entities to suit the fluidic changes that will be happening with ARDS. So these are some of the pitfalls with regard to mechanical ventilation in ARDS. And we spoke about asynchrony. So now the new artificial intelligence models and the algorithms have shown there is significant divergences with regards to synchrony. And it is staggering to note in this study that what we believe are normal breaths that we are giving, so 58% of the time there is ineffective breaths that are delivered to a patient when someone is on mechanical ventilator, which is shown with using this AI algorithms. And this was another study by Blank et al. Where they used AI algorithms to determine that 42% of the time there is no synchronicity between the scalars and the loops, and there are divergences that happens and deviance that happens, which means there is varying degrees of asynchrony bar dysynchrony that happens in a patient who is on a ventilator with ARDS. And even this study also showed there is some degree of dynamic hyperinflation that is there in any patient who is ventilated because of no concordance with the exhaled tidal volume and the inhaled tidal volume. So these are some of the studies, recent studies, as you see, using AI models, they have shown that there is no synchronicity between the breaths, and more than 50% of the breaths are asynchronous or dysynchronous. So that is about the pitfalls of ventilation. And when we are ventilating a patient with ARDS, we know there are awful types of lung injury that patient has. So I'm sure every listener from intensive care would appreciate there are various types of lung injuries that happen, and we need to adopt strategies to mitigate this. Like all of you know, there is a entity called ventilator-induced lung injury. So we won't dwell into the details, but this is a established entity which troubles the patients with ARDS. Then there's an entity called atelectasis because of closing and opening of the collapsed alveoli with an overinflated alveoli, which leads to atelectasis. Then we know there is an entity called barotrauma because of increased PEEP and intrinsic PEEP, which may exceed what is acceptable. That leads to barotrauma. Then there is something called biotrauma also. Biotrauma is where there is a lot of inflammatory exudates that happen in the alveoli. There's a lot of edema, there's a lot of inflammation, maybe hemorrhage also that happens within the alveoli that leads to disruption of the alveolar capillary interface, which we call as biotrauma. In addition to these four types of injuries that already happens in ARDS with ventilation, we also have a new entity which is pushed into our understanding called PCL. So although one can argue whether PCL is really an entity, this is also a new entity. So these are five types of trauma that we all have understood in any patient with ARDS who's on a ventilator, and we are trying to adopt strategies to mitigate these injuries. And how far we can be successful with this? It's very hard, isn't it? So that would be my argument that there are different types of injuries that patients have when they are ventilated. And to top it all, there is huge heterogeneous ventilation that happens because the lung is not homogeneous in ARDS. You have a varying degrees of alveoli that are recruited, derecruited, or overinflation because of the disease entity itself. And the ventilation also, in that sense, will be very heterogeneous. So these are all some of the pitfalls of mechanical ventilation. To top it all, we are talking about lungs. What about heart? And we have clearly understood now with multiple studies there is significant RV dysfunction that sets in patients who are vent. So ventilator is not very friendly for the heart in ARDS, especially when you are in a overzealous mode to optimize the peak. And RV dysfunction, these studies have shown sets in 30 to 56% of the patients with ARDS, and it has a significant bearing on increasing the 28-day mortality. And the reason for RV dysfunction is there is hypoxic or hypercapnic pulmonary vasoconstriction that happens, and there's a lot of microthrombi that happens in microcirculation in ARDS, and there is increase in the dead case. All these leads to severe strain on the RV and RV dysfunction setting, and there are certain predictors for RV dysfunction, especially in ARDS with PaO2 FiO2 by less than 150, or if someone has permissive hypercapnia, which happens, and you're talking about optimizing PEEP and permissive hypercapnia. So PaCO2 more than 48 is not uncommon in ARDS, and someone with a driving pressure of more than 18 centimeters of water. So any patients with more than or equal to two of these are at a risk of RV dysfunction. More than 20% of the patients with any two of these develop RV dysfunction. So this is the established entity and the pitfalls of ventilation. So now then, what is the solution? So now we have so many problems. So we have problems with setting the goals or attaining the goals. Then we have problems with RV dysfunction. Then we have problem with heterogeneity. So on and so forth. So then what? And we have five types of different injuries that happen in ARDS. So the solution one can look at from a futuristic standpoint in the conceptual A is ECMO. So obviously this debate was given with an intent that we talk more about ECMO as a strategy. So ECMO is safe, it is effective, and it is shown to be cost effective, especially from the Caesar trial. So there are two good randomized control trials with the role of ECMO in ARDS. The first one is the Caesar trial, which came in Lancet, published in 2009, done by UK group, UK clinicians. So this study was done in 92 ICUs in 11 hospitals across UK. So they recruited 180 patients, 1:1 randomization. The age group of patients was 18 to 65 years. So in Caesar trial, the inclusion criteria was severe ARDS, where Murray score was more than 3 or pH is less than 7.2. And the exclusion criteria is where peak inspiratory pressure is more than 30 centimeter or a patient needing FiO2 more than 80%, or someone who is ventilated for more than 7 days, someone who has an intracranial bleed or intracranial event. So the primary outcome they looked at was death or severe disability at 6 months. So what did they find? So it was a positive study. So the results, there were 90 patients in ECMO group, 90 patients in the control group. So if you look at the 6 month survival, it was 63% in ECMO, 47% in the control, and it did attain statistical significance. So this was a positive study, and all these the centers that were recruited, they had a referral process. So and the patients were sent to a place where ECMO was done for. So it was an ECMO centric centers where they were initiated on ECMO. So with optimal referral, so they achieved a plus 0.03 quality adjusted life year at 6 months follow-up. So which means they had a quality adjusted life years was added on to these patients who are on ECMO, and the cost for that quality adjusted life year. So they estimated the cost also, and that came to 19,252 pounds per year, which they found it as cost effective in the UK setting. So what the study basically tells is there was a good clinical outcomes, quality adjusted life years was added to these patients, and it appeared cost effective. So looked at the mainly cost effectiveness of ECMO in this particular study. So then came this Yolia trial, which came from the French group. So this was by Coombs et al. So because he went on to do a meta-analysis later. So the inclusion criteria in this Yolia study was PaO2 by FiO2 less than 50 millimeter mercury for more than 3 hours, or any patient who had PaO2 by FiO2 less than 80 millimeter for more than 6 hours, or like in the Caesar trial, pH of less than 7.25, or PCO2 more than or equal to 60 millimeter mercury for more than 6 hours. So these were the inclusion criteria for the Yolia trial. Primary endpoint was to look at 60-day mortality, and this was a larger study than the Caesar trial because Caesar had 180. This had 249 patients, 124 in the ECMO group, 125 in the control group. And 60-day mortality, as you see, there is signal towards being less 35%, although it did not attain statistical significance. And there was crossover. Crossover means in the control group, someone needed ECMO, they went on for ECMO. So 35 patients in the control group went on to ECMO group. So 28% of these control group who were changed, were shifted to ECMO because they needed ECMO. And in this crossover group happened at the 6.5 plus or minus 9.7 days was the time for randomization to happen for the crossover. And in the crossover group, the death risk was 57%. 20 patients who crossed over to get ECMO, 57% of them died. So that was about the Eolia study. So Caesar was a positive study. So Eolia shows signal towards some benefit, signal towards, but although it did not attain statistical significance. So then there were two meta-analyses putting in all these studies together. So this was a meta-analysis from China where they took 7 studies. So they took Yolia trial, Caesar study, along with 5 observational studies. So, and as you see, the number was cranked up. So 861 patients. They took all the studies. And when they only analyzed the RCTs, which is Yolia and Caesar, the 90-day mortality did attain statistical significance with ECMO compared to mechanical ventilation. And they looked at 30-day and 60-day mortality, taking all the observational studies together. They put all observational studies and they looked at 30 and 60 days mortality. Even there, it attained statistical significance with ECMO. So ECMO did show benefit when they took observational studies together. When they took the randomized control trial also, it attained statistical significance. And they looked at the adverse events, and adverse events, as you see, there was no difference between ECMO and mechanical. So this was the findings in the uh, Chinese meta-analysis. So the Coombs et al., who did the Yolia trial from the French group, he went on to do meta-analysis combining Caesar trial and the Yolia trial, like the Chinese did. So he took Yolia and Caesar, 429 patients, 214 in ECMO group, 215 in mechanical. When you look at 90-day mortality, it did attain statistical significance, significantly less in ECMO group as compared to ventilation. And in ventilation group, rescue ECMO was needed in 17% of the patients, and 35 of them were from Yolia out of 36, and one from the Caesar, where they were crossed over to ECMO group. 90-day treatment failure, when they looked at, was actually less. As you see, the treatment failure was less in ECMO as compared to mechanical ventilation. So when they say treatment failure, it is even the mechanical ventilation group who died or who had to come to ECMO group. That was considered treatment failure, or in ECMO group who died. So the treatment failure was less in ECMO as compared to the mechanical ventilation group. And ICU free days also was more in ECMO, which is good. So all in all, the evidence so far we have is too good for all the trainees, two good randomized control trials, Caesar and Yolia, and two meta-analysis. And this is a good meta-analysis where they have only taken Caesar and Yolia, and one Chinese meta-analysis which has taken 6 observational studies. So that's my argument. So we have a lot of pitfalls with mechanical ventilation because the goals that we set cannot be attained. And there are 5 types of injuries mechanical ventilation causes, and we are dealing with huge heterogeneous ventilation. And now there is an evolving evidence saying ECMO is favorable. So then obviously my opponent would argue with his own uh, narrative. So my rebuttal is, what is the way forward? So obviously I cannot strongly rebut and say we won't ventilate patients. The way forward is there is a concept of awake ECMO. So, and this started in way back in 2013. As you see, ECMO instead of invasive mechanical with acute respiratory distress syndrome. So, awake ECMO is a concept possibly we should all get sensitized to. And this was considered mainly in chronic lung disease as a bridge to lung transplant. And this is shown to be even feasible in ARDS. So, this is where we are coming. So, awake ECMO, what are the advantages? It reduces the ventilation perfusion mismatch. Patient is breathing. That's why it is very friendly to RV because the negative pressure, it improves the venous return, and all those deleterious effects of RV dysfunction we saw does not happen with awake ECMO. And it conditions the respiratory muscles because you don't need sedation, you don't need paralysis, you don't need analgesic. So you are conditioning your respiratory muscles, you're conditioning your diaphragm. So functional residual capacity is well maintained with awake ECMO. But having said all this, awake ECMO should be done in dedicated hospitals in a highly selected patients is what we can conclude. So the potential indication for awake ECMO is end-stage pulmonary disease or ARDS mainly secondary to trauma or to surgery is something one could think of, or immunocompromised where the risk of infections will be very high. And there is a already case series that is come out from South Korea where they looked at awake ECMO in patients with post-operative ARDS. It was case series done between 2012 to 15. 10 patients underwent awake ECMO, and this was all ARDS which developed in a post-operative setting, and 80%, 8 patients were weaned off. So one patient, 7 plus 1 is 7, were weaned off. One went to ventilation and again was brought back to awake ECMO and weaned off. And the duration of awake ECMO in this case series was 9 plus or minus 2 days. And the duration of mechanical ventilation in this was 6.8 plus or minus 4. So this was a study which came from Korea, which talks about awake ECMO in patients with acute respiratory distress syndrome. So this was a case series that came in 2012 to 2015. So it was a small series done in 10 patients where they showed awake ECMO in ARDS is possible, where about 8 patients were weaned off, 7 plus 1. So the one patient had to go back on ventilator, but then again weaned back to awake ECMO. And the duration of awake ECMO was around 9.13 plus or minus 2.2 days. And the duration of mechanical ventilation in this series was 6.8 plus or minus 4.7 days. So my conclusion is extracorporeal life support or ECMO does not do any harm from the studies that we have seen. It can be delivered safely, and studies have shown that the organ failure rates are much lower in patients who are on ECMO. And it is safe to say that when someone is not put in ECMO, some of them would die, and no survival happens in some without ECMO. Where if you don't offer ECMO, these patients are going to die. So that would be my summary statements on this. So thank you one and all. So I request each of the listeners here to present their valuable work to the Journal of Acute Care, which comes out every 3 months. You can visit my website www.drpradeeprangappa.com to read to this lecture. So thank you all. Thank you one and all.